Hello and welcome to our program titled Ushering in a New Era in the Treatment of Chronic Kidney Disease and Anemia, Appreciating the Patient Burden, Exploring Pathways and Pathogenesis, Reflecting on New Emerging Data. I'm Dr. Ajay Singh, Senior Associate Dean for Postgraduate Medical Education and Director of the Master in Medical Sciences Clinical Investigation Program at Harvard Medical School. I'm also a nephrologist at the Brigham and Women's Hospital here in Boston. I'm joined today by my esteemed colleagues, Dr. Edgar Lerma, Clinical Professor of Medicine from the University of Illinois in Chicago, Illinois, and by Dr. Jay Wish, Professor of Clinical Medicine at the Indiana School of Medicine. Dr. Wish serves as Chief Medical Officer for Outpatient Dialysis at Indiana University Health in Indianapolis, Indiana. The faculty disclosures are displayed on the screen for your convenience. This program is supported by an educational grant from GSK. We would like to thank them for support of this initiative. The learning objectives for this initiative is as follows: recognizing disparities in the management of anemia in CKD. And I'll turn this over now to Dr. Wish.
Patient-centered care in the treatment of anemia is something that's extremely important and has perhaps been overlooked due to the diversity of the patient population with this condition. If approved, HIF-PHIs will shift the paradigm for CKD anemia treatment. It will offer a greater choice of therapy, especially replacing an agent such as an ESA that has to be given parenterally with one that can be administered orally and does not require trips to a healthcare provider. So some of the patient factors to consider include the biological and clinical factors of the patient. Again, patient-centered issues such as age, developmental programming, sex, genetics, comorbidities, and ongoing treatments. And this kind of wraps around the whole issue of social determinants of health. And we know that these social determinants of health can be major barriers to effective therapy in the setting of CKD and CKD-associated anemia, which disproportionately affect patients of color and patients with economic disadvantages. So economic stability, the neighborhood and physical environment, the educational level of the patient and caregiver, the diet of the patient, the community and social context in which the patient is receiving their healthcare, and the healthcare system per se are all ultimately determinants of healthcare and the success with which we provide treatment to patients with conditions, including CKD-associated anemia. So let's examine some of these health disparities and social determinants of health in this patient population. In this slide, you see the social determinants of health role in anemia chronic kidney disease, and there are a number of key social culture determinants of healthcare provision. We have to consider the genetics and biology of the patient, as well as the environment, the nurture versus nature. Both have significant impact on our ability to provide effective health care. On the left-hand side in the green, you can see a variety of issues that include poor communication, health literacy, which tends to be low, a variety of economic and neurohormonal issues, which provide stress and may ultimately impact on the effectiveness of the therapy, low employment, poverty, poor education, limited healthcare access, and ultimately issues such as alcohol and substance abuse, which may further impair the ability of the patient to understand their condition and to understand the importance of their receiving the therapy as prescribed. There's marginalization from the majority of society, discrimination, a variety of issues leading to poor nutrition. This can lead to obesity, diabetes, hypertension, cardiovascular disease, all contributing to the chronic kidney disease state. And also must consider residential segregation and other environmental factors that contribute to socioeconomic disadvantage and disengagement from the healthcare structure. So as you can see over on the right-hand side of the slide, many of these impact on some of the common causes of anemia and chronic kidney disease. And the ones in bold in particular include the iron deficiency that results from poor diet, blood loss that may result from trauma, a socioeconomic disadvantage, housing, etc., the inflammatory state of chronic kidney disease, infections that may be more common in a poor healthcare and housing environment, and then the nutritional deficits that can occur. So ultimately, the minority populations that inhabit these socially disadvantaged environments are going to be at higher risk for kidney failure. If you look at the rates of kidney failure from diabetes alone by race and ethnicity in a publication in 2013, you can see whites have a rate to the right of that green outline that is significantly lower than that of Hispanics, Blacks, Asians, and Native Americans. And if you look at the health care that these patients receive, then in this particular pie diagram shows the presence of clinical factors for CKD in non-Hispanic Black participants. 44% had risk factors for CKD, and yet only 24% were screened for CKD. And finally, if you look at the prevalence of pre-dialysis care from nephrologists among hemodialysis patients by ethnicity, and this is usually in the 1 year prior to dialysis initiation, you can see that 52% of Hispanic patients receive pre-dialysis nephrology care, whereas only 44% of non-Hispanic Black patients receive nephrology care. So the non-Hispanic Black population seems to be at greatest risk for some of these adverse outcomes from their chronic kidney disease, one of which is anemia. And in this slide, you can see the prevalence of CKD anemia. In the anemic cohort of patients, you can see the overrepresentation of Black non-Hispanics, which was 50%, despite the fact that they represent only around 13 to 14% of the general populations. So overall, 70% of the anemic cohort was from minority populations, and only 40% of the non-anemic cohort was from minority populations, which, as you can see in the second pie diagram to the center of the slide, was 52% white. Lower socioeconomic status puts you at higher risk of anemia. If you're low income, you're much more likely to be anemic than non-anemic. And if you have less than a high school education, you're much more likely to be anemic than non-anemic. So some of the strategies to mitigate healthcare disparities in CKD anemia can be seen on the following slides. Obviously, we want to emphasize patient-centered care, which specifically addresses many of these disadvantages and barriers to the effective diagnosis and treatment of these disorders, the CKD, the anemia, and the overall health of the population. So it's ideal that we assemble a multidisciplinary care team. We develop a strategy for educating patients about CKD anemia so they understand the nature of the disorder, what the risk factors are for developing the disorder, the diagnostic tests that can be used to document the presence of the disorder, and the reasons why they need to be perhaps more engaged in the treatment of the disorder because of the adverse outcomes that it may be associated with. We want to identify community resources, include family and caregivers, as well as the patient's community in the treatment and educational efforts. And this is not autopilot. We need to periodically reassess the effectiveness of these strategies in terms of achieving the outcomes that we are trying to achieve. So identification and diagnosis, developing and implementing the detection protocol, targeting the populations at risk. And as you saw in the previous slide, it's the minority populations that have significantly higher rates of CKD associated with diabetes. And the example that I presented, leveraging health information systems, promoting detection at every opportunity, and measure, tracking, and improving as we can. This is the typical Shewhart cycle, find, do, check, act of quality improvement. Ultimately, the treatment and monitoring will integrate evidence-based guidelines, educate the patients, and monitor the CKD progression, not only of individual patients, but of the population per se. So we have treatment choices, or at least we would like to have treatment choices in terms of treating anemia with the standard of care, which has been ESA since 1989. They have a track record of established efficacy. They may reduce fatigue and improve quality of life, although this is debatable depending upon the study. And they have a known safety profile. They're not completely safe, but at least we know what their issues are in terms of safety. The cons are obviously that they require iron administration because they have no direct effect on iron mobilization or absorption. There are cardiovascular risks with higher doses that were documented in a variety of large-scale trials, including the CREATE trial, the QUIRE trial, and the TREAT study. There is a subset of patients who are hyporesponsive, perhaps 10%, in whom escalating doses of ESAs are ineffective in achieving target hemoglobin levels. They require cold storage and cold transportation. And again, parenteral administration can be an inconvenience to many patients. The HIF-PHIs, none of which is yet approved in the United States, do offer several potential advantages. They're clearly superior to placebo in improving hemoglobin. They've been non-inferior to ESA in almost all the global clinical trials of the agents in terms of raising the hemoglobin level. Some of the agents have been shown to decrease the need for iron supplementation, and especially for patients who have adverse reactions to oral iron or are unable to go to a healthcare provider, infusion center to receive IV iron. This can be a significant advantage. Of course, they're orally administered, which is a huge advantage in patients who have trouble accessing subcutaneous or IV EPO, and there's no cold chain requirement. The cons are that there isn't a lot of long-term safety data. So clearly additional safety studies are needed to look at major adverse cardiovascular events, increased risk of thrombosis, including DVT and pulmonary embolism and vascular access thrombosis among patients on dialysis. There's the issue of tumor progression because of their effect on angiogenesis, because they may increase the vascularity of tumors and promote their growth. And there's been a suggestion of an increased incidence of upper GI erosions in the daprodustat trials of non-dialysis patients. But again, there's a question of whether or not this is an effect of the analysis. So the key takeaways are that if approved, the HIF-PHIs will expand treatment options for CKD anemia. And choices are always good in clinical medicine. Patients should be given education about the advantages and disadvantages of a number of potential treatments and be given the opportunity to weigh in terms of what their preferences are. That is patient-centered care. So it's important to consider some of these healthcare disparities as they impact on our ability to deliver patient-centered care. Clearly, minority populations are at greater risk for not only CKD, but also CKD-associated anemia, and are often underserved in clinical practice because of access issue, education issues, environmental issues, et cetera. So several strategies are aimed at improving disparities, policies and protocols that can be standardized across populations to emphasize patient-centered care and education regarding their risks for adverse events in the future, and ultimately individualizing care to incorporate an understanding of the barriers, increase education, and deliver the care that that particular patient population needs to ultimately improve outcomes.
Well, that was a really interesting presentation, Dr. Wish. Let me position this now with a case which I think would be valuable for you and Dr. Lerma to discuss. So this is a 78-year-old man who lives in a rural community in Montgomery, Alabama. He has stage 4 CKD from type 2 diabetes, but also has hypertension. He's legally blind because of advanced diabetic retinopathy. He's on multiple medications. Of course, you can imagine these include diabetes medications, hypertension medications, as well as medications to slow progression. He has mobility issues. He receives care from multiple caregivers, physicians that include a diabetologist, a primary care physician, and a nephrologist. He has a visiting nurse who comes in to see him twice a week, and a home help aide. He's in touch with a diabetes educator through the diabetes practice in his area. Now he has anemia that, because of difficulty in access, has not been consistently treated. And indeed, he's missed several appointments to receive his subcutaneous erythropoietin. And I wonder if you could both just discuss what your thoughts are about this case and what how patient-centered care is really important in thinking through this type of situation.
So this is a good example of a housebound patient who could potentially benefit from a non-parenteral therapy for his anemia. Obviously, we don't have all the details in terms of what a visiting nurse can and can't do. We don't have information about what the payer will and will not allow. But assuming that the visiting nurse is not able to give him his EPO, because he's missed several appointments to receive EPO in a clinic, so I have to assume that that's required by the patient, by the patient's payer, then this would seem to be almost a poster child of a patient who could not receive the EPO and therefore has more severe anemia than would otherwise be the case. Edgar, do you have any comments in terms of whether or not you would think that this patient would benefit from an oral anemia therapy?
So definitely, I this is the picture of this patient depicts the typical patient that we see in the clinic. CKD secondary to combination of diabetes and hypertension. So this patient really fits that mold that he needs to be his anemia needs to be treated, and he's not getting the right treatment because of the distance, mobility issues.
The other question that I think is relevant to this patient is, as we mentioned in one of the earlier presentations, transfusion is the treatment of anemia in last resort. And we try to avoid transfusions in most of our patients because there's obviously risk of the blood, but there's also the issue of allosensitization for future transplant. This is a 78-year-old man. He has multiple comorbidities. He could potentially be a candidate for transfusion because he's probably not going to be a transplant candidate. Edgar, do you think we should be discriminating that patients who are not transplant candidates are more suitable for transfusion, or should we still consider it a treatment of last resort for anemia and perhaps favor an oral anemia therapy like a HIF-PHI in a patient like this?
So one other disadvantage or one other problem with giving transfusions is obviously the burden of travel, right? Again, this patient already has difficulty ambulating and traveling back and forth. Certainly, that's one issue. Aside from the, obviously the allosensitization issue, but he has to go to a place, another center where he could get a blood transfusion. But we also know that transfusions have attendant risks of higher infections. There's always also that risk. And again, I think this is an issue that again sort of hammers the importance of being able to identify an oral agent who would provide the same benefits as transfusion. And of course, I'm going to just bring up another issue that sometimes we see. Patients who are of certain religious denominations, they cannot have blood transfusions. And that's another patient population that might benefit from this oral agent.
That's a very good point. So the transfusion option is sometimes not available for patients who have religious objections to transfusion. What about the other potential beneficiaries of oral agent? We talk about somebody who's CKD, but what about a patient who's on dialysis and is on, excuse me, home therapy, and also perhaps maybe in a rural location, has to travel a long distance to get an ESA injection? Would that also be an appropriate candidate for an oral therapy?
I think so. This is another patient population, the home dialysis patients on PD, whom we normally see once a month. And sometimes if we identify them as having EPO resistance or EPO hyporesponsiveness, what happens is that we have to have them come back to get their shots. And again, we bring back the issue of travel, the burden of travel. Traveling is not only an inconvenience, it's also inconvenient on the pocket. So that's another issue. And of course, some of these patients may have caregivers. The caregivers have to go with them. And so that's another loss of work, productivity issues.
Absolutely. And, that's a good point that we often fail to consider the caregiver burden in patients with CKD, and especially if we're talking about an anemia treatment that requires transportation, either for a transfusion or for an ESA, then we also have to factor in how that affects the life of the caregiver, the work productivity of the caregiver, et cetera. So again, I think, as you point out, an oral anemia therapy to replace ESAs and certainly to try to decrease transfusion requirements would be most welcome in a situation like this, and probably extrapolate to almost any situation where there's difficulty in going to a clinic or other healthcare site where such treatments such as ESAs and transfusions must be given. So an oral therapy, I think, offers extreme promise to a variety of situations among patients with CKD-associated anemia in terms of replacing current therapy.
Well, thank you. We've reached the end of our allotted time for today. I'd like to thank my colleagues, Dr. Wish, for a great presentation and a lively discussion surrounding patient-centered care in treatment of CKD anemia. I'd also like to thank Dr. Lerma for his contribution to the discussion. Also, we'd like to thank GSK for their support of this program. We would like to ask learners to please follow the link that is provided at the end of the program and in the thread below to fill out this evaluation and post-test in order to receive CME credit. This provides us with valuable feedback that will be used for the planning of an upcoming program. This is the final part of the 4-part series. If you missed any of the sessions, we will be launching an enduring 1-hour program. Please follow the Iridium CE social media, Twitter, or Facebook page so you can be notified when this program launches. Thank you again for joining us.